So our topic is on MSICS and the challenges that commonly we face and how to overcome these challenges consistently. Without much wasting time, let us start off with the first presentation, which will be by Dr. Aaditya, Scleral tunnel related challenges.
Good morning, everybody. Such an honor to be the first speaker of the Drushti meeting. Thank you, KSOS2024IC11T5 organizing committee, Dr. Scleral, for giving me this opportunity. So right away, we will start with the topic. I'll be talking upon the scleral tunnel related challenges in SICS. Why scleral tunnel is so important? Because it gives a more oppositional surface and improves the wound healing. It can reduce the surgical induced astigmatism. Then it creates a three-valve mechanism which makes the tunnel self-sealing, and hence it becomes a sutureless incision. This is how the cross-sectional anatomy would appear. How the good tunnel should be. It should have a square geometry so that it gets a good strength. The external incision should be a smaller one than the internal larger incision. And the side pockets or the scleral pockets should accommodate the nucleus when it comes out of the anterior chamber. For a beginner, as such, when he is doing a superior incision, taking a bridal suture is very important so that he gets a good surgical exposure, followed by an adequate limbal peritomy. Do remember to clear the episcleral tissue also, otherwise the incision will be very ragged or irregular. And then do a minimum cautery. Do not over cauterize, otherwise it can cause more scleral inflammation and thinning later on and may lose the valve mechanism also. For the external incision, the size, shape, location, depth of incision all contribute to a good scleral tunnel. The size mainly depends on the hardness of the cataract, but longer the incision or it gets closer to the limbus, it can cause more astigmatism. So to negate that, there was a concept of astigmatically neutral tunnel explained by Koch. The arrows here point towards the incisionally neutral tunnel. Where the incisions which are made in this funnel are astigmatically neutral or they create less astigmatism. So the incisions like Fron, Blumenthal or Chevron mostly lie in this funnel and they create least astigmatism as compared to the Smile and Straight. Sorry. Even the site of incision is important. A superior incision is more stable, but it can flatten the vertical meridian and cause more astigmatism as compared to the temporal one, which can neutralize the pre-existing astigmatism, which is common with old age. For creating an external incision, the first and foremost, a good hold should be there with your left hand instrument. The blade can be either a crescent knife or 11 number blade or a guarded knife for a beginner. The knife should be perpendicular to the sclera and should reach around half the scleral thickness. The previous was a Blumenthal incision, even the other one which I am showing here is a Fron incision. As you can see, it should go in single pass so as to create a clean, clear cut. Next is sclerocorneal tunnel making. This is the most important step. Once we get the first external incision, we should score the incision a bit if it's not correcting the up to the half scleral thickness. Then with a wiggling movement, we should go along the contour of the globe. That is, the scleral contour is different and the corneal contour is little bit more steeper. So we have to follow that contour, go with a wiggling movement, and to identify the thickness, how much we have reached, we can get this show of the crescent knife. I mean, if it is too clearly seen, that means we are superficial. If it is correct plane, it will be translucently seen. And when it is deeper, the view of the crescent blade will be very less. Then we should be cutting inside out. And at the end, we should make these scleral pockets, as you can see here. These pockets will allow nucleus to be accommodated during its extraction from the anterior chamber. But sometimes the things may not go well for a beginner every time. He can have buttonholing or flap cuts. Like here you can see the crescent blade is not at the correct plane, it is more superficial. And when the surgeon is trying to make the scleral pockets, he goes through and that's how the buttonholing has happened. These incisions will require suturing because otherwise they will keep on leaking later on and have more complications even intraoperatively. In another place, surgeon had this scleral flap cut as you saw over here. But then he was skilled enough, he went from the other side, got to the correct plane, and then he could negate this scleral flap cut so that it doesn't go through and through. So superficial tunnels can cause buttonholing, scleral tunnel deroofing, but the deeper ones can sometimes lead to uveal tissue trauma. We can have a premature entry which will cause leaking wounds, and there will be more risk of iris prolapse. The internal incision globe should be firm enough with a viscoelastic inside. The keratome should be quite sharp, and then we have to dip into the near the internal plane what we have made, and then dip into the anterior chamber. The knife should be parallel to the iris plane. These incisions are usually sutureless, but we will have to suture them if they are quite irregular or if those incisions are quite large. If we have any eventful surgery like iris prolapse or premature entry, if anterior vitrectomy was required, or there is a Descemet membrane detachment where gas is to be injected into the anterior chamber, or if the patient is one-eyed, also we should be suturing these tunnels. So the tunnel is the first stepping step of the good SICS. All the size, shape, site, everything is important for having a good, strong, stable tunnel. Assessing the correct depth is the first important step, followed by following the contour of the globe. The knife should be sharper and the correct dissection planes should be followed. Suture is to be done whenever necessary. And wet lab practices are the most important thing to go ahead with the actual surgery, because wet lab practice will give us a good assessment and control on our surgical steps. Thank you.
So thank you, Dr. Aaditya. Dr. Aaditya is a phaco-refractive surgeon from Amida Eye Care in Tiruvalla. He's also a phaco trainer for PG students in Amida Eye Care. Thanks a lot for your presentation.